Welcome, everyone. Whether it's morning, afternoon, or evening where you are, we appreciate your making time to learn more about the family planning work being carried out under the USAID-supported PROPEL Health project. I'm Jay Gribble, Deputy Project Director for Family Planning and Reproductive Health of the PROPEL Health project, and I'm happy to facilitate our webinar today. Our session is being recorded, and the link will be forwarded to you in the next day or two. You can ask questions or add comments during the presentation in the Q&A tab across the top of the screen. And toward the end of the session, I'll facilitate a discussion with our presenters. Today begins with a welcome from the director of the PROPEL Health project, and followed by opening comments from the director of USAID's Office of Population and Reproductive Health. Then I'll introduce our speakers, who will present the case studies on some of the aspects of our family planning and reproductive health work. And here you can see who our speakers are: Suneeta Sharma, Shyami de Silva, Francis Ilika, Laura Hurley, and Erin McGinn. So let me turn it over to Suneeta Sharma, Director of PROPEL Health, to share some opening comments about the project.
Thank you, Jay, and thank you for joining us today. PROPEL Health sustains and advances the family planning and reproductive health achievements that USAID and its country partners have driven over the last 5 decades. We are a global project and now have activities in 22 countries across Africa, Asia, and Central America, led by a stellar group of local experts. Increasing access to voluntary family planning is at the core of everything we do, from policy, financing, governance, and advocacy approaches that you will all hear about today, to data and evidence generation, human resources for health, and fostering multi-sectoral engagement. Our efforts are grounded in the knowledge that access to family planning is vital to save motherhood, healthy families, and prosperous communities. We take an integrated systems approach to improving health outcomes. Malawi is a great example of this. PROPEL Health supported the integration and alignment of several policies to the National Health Sector Strategic Framework and Vision 2023. This includes the National Population Policy, the country's Family Planning 2030 commitments, the Digital Health Policy, the National Multi-Sectoral Nutrition Strategic Plan, and more. Bringing them in alignment under one broader framework is strategic for sustainable domestic financing, improved stewardship and accountability, and effective implementation of these strategies. People-centered primary healthcare is the most efficient, impactful way to provide health services. So PROPEL Health focuses on family planning, integration with HIV, maternal child health, and primary health care. PROPEL Health strengthens health systems to be resilient and sustain access to essential health service delivery in the face of disruptions. We promote an accountability mindset among our partners and strengthen decision-making capacity with sound data, evidence, and by scaling locally led innovations. You will hear more from my colleagues today, but I would like to share one result that helps define our impact. It is a great example of how civil society and government champions can work together to secure public funds for contraceptives. In 2005, Guatemala passed a law on universal and equitable access to family planning that set a 15% tax on alcoholic beverages to fund family planning programs. This was a groundbreaking law at the time, but its application has been varied. Since that time, and with support from USAID-funded policy projects, there have been several key interlocking components coming together, which have been instrumental in helping sustain contraceptive financing. This includes a motivated civil society, evidence-informed advocacy, policy dialogue, long-term donor technical support, strong policies and regulations, and joint civil society and government monitoring of policies. This year, with PROPEL Health support, the Ministry of Health conducted a financial budget analysis to advocate to Congress for a family planning increase. And in August, Guatemala's Congress approved a 9% increase in the ministry's health budget. Of this, 2.1 million is specifically allocated to the reproductive health program. This is a significant achievement, and the first time the Ministry of Health will actually get the full 15% of alcoholic beverages tax revenue. At the local level, this means additional funding for family planning committees and investments and hiring the necessary local personnel to provide better comprehensive services to the entire population. I love to share this example because it demonstrates how policy, financing, advocacy, and governance all come together in a comprehensive way to advance family planning. The operationalization of Guatemala's reproductive health law demonstrates policy to action, or I would like to say allocation to use. This example shows how a multi-sectoral array of local actors and partners can develop solutions that help countries meet their family planning goals. And with that, it is my pleasure to be able to introduce Shyami de Silva, who is with us today. Shyami is the director of USAID's Office of Population Reproductive Health, the holder of the PROPEL Health. Shyami provides high-level leadership to the agency's $600 million family planning and reproductive health agenda. She directs the office's $100 million portfolio of global health leadership investments. Shyami has over 25 years of experience designing, managing, and evaluating family planning and HIV programs, has served as a project manager, researcher, and technical advisor on such issues as engaging the private sector to achieve public health outcomes and global financing trends for reproductive health. I'm so grateful to her for her leadership at USAID and globally. Thank you.
Good morning, good afternoon to everyone. It's wonderful to be with you virtually today. Many thanks to Suneeta for that very kind introduction, and also to the PROPEL Health team for organizing today's webinar. I'd like to open just with a few words about USAID's Family Planning and Reproductive Health Program and how the work that we'll hear about in today's webinar contributes to advancing our shared goals. Our office recently launched a framework that outlines the direction of USAID's Family Planning and Reproductive Health Program through 2030, and it's entitled Pathways to Progress for Sexual and Reproductive Health. In that document, we articulated the following vision: that USAID's Family Planning and Reproductive Health Program works with partner countries to realize a world where ongoing improvements to sexual and reproductive health contributes to longer, healthier, and more prosperous lives for all. So to achieve that broad vision, we work in partnership to expand access to high-quality health services, to broaden the availability of contraceptives, and to strengthen policies and systems to address a range of family planning and reproductive health needs. The Pathways document focuses on opportunities at multiple levels, at the individual, systems, and societal levels, with three broad goals in mind. First, ensuring that all individuals have the information, skills, and ability to achieve the highest attainable levels of sexual and reproductive health. Second, to strengthen health systems to provide quality, accessible, and people-centered sexual and reproductive health care. And third, to foster positive social and gender norms and policies that support full agency in making sexual and reproductive health decisions. The work that we will hear about today spans multiple pathways. For example, PROPEL Health seeks to address health system policy, financing, and advocacy, as Suneeta was just talking about, and governance by strengthening institutional and individual capacity for improved health services. The project also works through these policy and governance levers to enhance the integration and delivery of primary health care services. PROPEL Health also collaborates with a wide array of experts, including government ministries, civil society organizations, the private sector, and family planning technical working groups. And this diverse network of thought partners and leaders both brings together proven strategies and also fosters innovative approaches to expand access to and utilization of family planning services. During today's discussion, you will hear about initiatives to mobilize funds for family planning, collaborative efforts with stakeholders to leverage data for improved performance, and strategies to expand insurance coverage to include family planning benefits. So these efforts highlight just a few of the ways we can use resources efficiently while also strengthening the capacity of local stakeholders. So it's wonderful as I look at the participant list to see participation from our missions on this webinar, and I hope you all will find today's conversation enriching and inspiring and be able to take with you some ideas that are applicable and adaptable to your country and regional contexts. So many thanks to all of you for joining. And with that, I will pass the virtual mic, I think, back over to Jay.
Thanks so much, Shyami. We really appreciate your thoughts and insights on the priorities of the Office of Population and Reproductive Health, as well as how the PROPEL Health Project is advancing these pathways to progress. And to illustrate some of the ways that we're supporting those pathways, I'm happy to introduce the case studies that my colleagues will be sharing. Our first case study focuses on how PROPEL Health is incorporating family planning benefits into state-supported insurance packages in Nigeria. Our presenter is Francis Ilika, a director in Palladium's global health practice. As a Nigerian, Francis understands the intricacies and politics of expanding health insurance benefits, having carried out that type of work under Health Policy Plus project to incorporate HIV services into the insurance benefits in Lagos State. As you will hear, expanding the insurance benefits requires technical understanding of service delivery, of health financing, and that important capacity to know your audience and communicate effectively to them. Our second case study considers how stewardship and performance monitoring are critical to policy implementation and achieving results. Our presenter is Laura Hurley, also a director in Palladium's global health practice, and she leads our work on costed implementation plans. Whether talking about CIPs or any other type of policies, we know that policy approval is only the first step, and sometimes it seems like the easiest one. However, through working to support stewardship capacity of Madagascar's Ministry of Health, we observe greater accountability mindsets among both the public and private sectors, and greater capacity to follow through on CIP commitments. And through working with the Family Planning Technical Working Group on performance monitoring, we see how they use data on key indicators to achieve the milestones and results included in the CIP. Our third case study highlights some of the innovative approaches that we're using to advance progress on these pathways. Erin McGinn, a director in our global health portfolio, will present on 3 innovative approaches. In Liberia, we're drawing on the experiences of core partner Samasha Medical Foundation to adapt the WHO self-care guidelines and sandbox them or pilot them before they're approved, and this work will be happening in one of Liberia's districts. In Guatemala, project partner Busara is using a behavioral science methodology to identify opportunities for better implementation of the country's gender-based violence policies. And in Côte d'Ivoire, we are incorporating climate data into our work with community health workers to have a better understanding of how climate is changing the country's epidemiologic profile, as well as the shifting demand for and distribution of CHWs. Following the presentations, I'll moderate the discussion with presenters, so please remember to add questions and answers and comments under the Q&A tab at the top of your screen. So our first presenter is Frances Ilika.
Thank you very much, Jay, for the introductions. And I'm happy to share the Nigerian experience with you of how Nigerian actors are exploring family planning integration into health insurance as a mechanism of expanding universal access to essential family planning services. By way of context, Nigeria is the most populous country in Africa. It's said to be on its way to double its population by 2050. And it is often said 1 out of every 5 Africans is a Nigerian. And this is driven by high fertility rates and low contraceptive use. In addition to that, there are a lot of other factors that impact negatively on maternal and child health indices with high mortality ratios. To worsen this, family planning spending in Nigeria is highly donor dependent. But despite the contributions of donors, 70% coming from donors, there's still a huge funding gap that needs to be filled. And this keeps getting bigger and bigger every year. So in a bid to combat this, of course, Nigerian government actors are making a lot of efforts, including signing on to the Family Planning 2030 commitments. And some targets here include raising MCPR from 12.7% in 2018 to 27% by 2030. And also allocating 1% of the health budgets to family planning, but also strengthening the integration of family planning into national frameworks. Other important policies include the National Health Act that mandates health insurance coverage for all Nigerians, and other policies including state health insurance schemes, which we'll be hearing about soon. But despite this, most health insurance packages at the state level include only a minimal package of family planning services, and some of them don't even include family planning services at all. It is known that family planning access would have a wider health system impact that will have gains for other health sector interventions, as we can see from the graph. But action needs to happen. So the journey in Nigeria has been ongoing, with stakeholders calling for family planning integration. And in 2023, PROPEL Health began to provide support to the government of Nigeria to help to drive this very important reform. So we're providing support to the Ministry of Health, health insurance agencies, and other parastatals. And to do this, we recognize that family planning integration provides enormous benefits, as shown in the graphics, where we can see that it will not just increase availability of family planning services, but it will also lead to improved outcomes, and also make sure that there is financial protection from poverty and hardship for people and families, which will have economic benefits in addition. So our approach was to do a systematic situational analysis that looked at evidence across technical, operational, regulatory, and financial feasibility. And we collected evidence from KIIs, DEX reviews, stakeholder consultations. And following that, we supported extensive stakeholder engagement with different government actors representative across the 6 geopolitical zones in Nigeria, but also across different parastatals like government, civil society, health providers, private sector, to bring everybody together to a round table where actors sat together, examined evidence, and set up a core team of major health actors within the country to come up with what we call the recommendation document for family planning integration into health insurance. And so right now, efforts are being made to domesticate this policy document so that it could lead to inclusion of family planning services into health insurance, but also its implementation. So stakeholders actually came up with a consensus to include a comprehensive package of family planning services, as we can see in this slide. Based on our analysis, only very few state health insurance schemes had family planning services included, and mostly at the primary level. But the recommendation that the stakeholders came up with is a comprehensive package of services like we can see on the screen. across both primary and secondary levels. But this work didn't just stop at that. It also provides guidance on provider engagement and how to pay providers, the roles and responsibilities of different stakeholders, the coordination mechanisms that will need to be taken, and the how-to guides for decision-making and monitoring results, including ensuring quality of care of family planning services through health insurance. We strongly believe that this integration, when successfully applied nationally, has the potential to become the game changer and help Nigeria advance on its FP 2030 targets. For instance, a back of envelope estimation that we made using government's targets. So government currently has a target of increasing its health insurance enrollment up to 19 million by 2027 and to 34 million by 2030. But I can tell you that as we speak, most states have actually even exceeded their 2027 targets. So this even has a bigger promise than what we can see here. So family planning can actually increase the number of women using modern contraceptive methods between now and 2030 by 100% based on a back of envelope estimation that we did. And this actually use very modest estimates because from what we can see, they have the capacity to actually exceed this. And this took into consideration the global evidence that showed that 65% of women of childbearing age with health insurance coverage will utilize modern contraceptive methods. So family planning stakeholders are excited at the enormous possibilities that this approach provides in the coming years towards helping Nigeria to meet its targets and improving health outcomes and curbing population growth in the country. At this juncture, I am delighted to pass it on to my colleague, Hurley, who will share the Madagascar experience of how CIPs are helping to drive FP results.
Thank you, Frances. So I'm pleased to be here today to talk about our work supporting the Family Health Directorate of the Madagascar Ministry of Public Health to manage the performance of their costed implementation plan for family planning. I'll start with a little background on costed implementation plans, or CIPs. Since the London Summit in 2012 and the launch of FP 2020, at least 42 countries have developed at least one costed implementation plan for family planning. In 2022, Palladium, through the Health Policy Plus project, conducted an assessment to identify and harness lessons learned for CIP planning, development, resource mobilization, and execution, and provide recommendations to improve upon the CIP approach to better meet the needs of country family planning programs. The assessment was conducted through an online survey, and survey responses were received from 47 people in 30 countries. In the first part of the survey, multiple choice questions gathered information on whether or not individual countries completed CIP steps and used CIP tools. This graph shows that the 2 steps in the planning phase were conducted by nearly all 30 countries. The steps in the development phase were also conducted by the majority of countries, with a range of 77 to 90% of countries conducting each step. Phase 3 is where countries hit a roadblock, as is often the case with many policy and strategy endeavors. Momentum always starts strong, but once a policy is launched, it can be hard to keep motivation up for implementation and monitoring. Only about half of countries reported providing effective stewardship, conducting performance monitoring, or developing and implementing the resource mobilization plan. We also found that countries with direct donor or project support for the CIP execution steps were more likely to implement these steps. Due to these findings, PROPEL Health developed an activity to focus our approach on strengthening local capacity to advance effective stewardship, to ensure strategy implementation, financing, and performance monitoring, and promote sustainability of the CIP execution approach. This capacity strengthening work in Madagascar focuses on the Technical Working Group for Family Planning, or GTTPF, which is led by the head of the Family Planning Service at the Ministry of Health. At the beginning of PROPEL Health, we supported the Technical Working Group to conduct a self-assessment on their stewardship capacity. This self-assessment included questions on the 6 functions of stewardship: generating intelligence, formulating strategic policy direction, ensuring tools for implementation, building coalitions and partnerships, ensuring a fit between policy objectives and organizational structure and culture, and ensuring accountability. We then conducted a training on stewardship and leadership in December of last year. Then in March of this year, we conducted a training on resource mobilization that included examples of resource mobilization successes in other countries, various methodologies for conducting financial gap analyses, and budget advocacy. We are currently working with a local IT firm to develop a dashboard before we move forward with the performance monitoring training. Through HP Plus and PROPEL Health, we have been supporting the Madagascar Technical Working Group since 2016, supporting the development, execution, and evaluation of their first CIP, and now supporting the execution of their second CIP. They monitor key indicators aligned to the beneficiaries and the priority results in their CIP. In this time, the modern contraceptive prevalence rate has increased more than 1% every year, up to 46.3% in 2023 for married women. This is a 13% increase since 2012. Several factors have contributed to this progress. First, there's political engagement at the highest levels for family planning and the demographic dividend. Next, the Reproductive Health Law of 2017 increased access to family planning for youth and unmarried women. Stakeholder engagement has been multisectoral with key participation in the technical working group from the Ministry of Health, Ministry of Population, and the Ministry of Youth and Sport. Local NGOs and youth associations have joined the technical working group and participate to ensure youth priorities are incorporated into the CIP and are monitored. Investments were made in both service delivery and demand creation with a particular focus on community health. Since 2016, when the first CIP was developed, there's been continuous resource mobilization in Madagascar. Several financial gap analyses were conducted with our support, and one led to the identification of a lack of resources for demand creation that then resulted in financial support to the Ministry of Population from Médecins du Monde and for these activities in the CIP. Likewise, advocacy was successfully conducted both for the removal of taxes on family planning products and for increased domestic resources for family planning. As you can see in this table, COVID-19 caused a dip in domestic financing in 2020 and 2021, but the funding levels have since recovered and exceeded targets in 2023. While Madagascar is still heavily donor dependent, the increase in government resources shows a commitment to family planning sustainability. So to summarize, the technical working group in Madagascar has come together over the last few years to steward the implementation, monitoring, and advocacy for additional resources for the CIP. This coordinated action will help promote sustainability of the family planning program in Madagascar in the years to come. So thank you for your attention. I'm now going to pass this over to my colleague, Erin McGinn, to talk about some of our innovative approaches.
Thank you very much, Laura. So I'm very excited to talk about some ways PROPEL Health is innovating in our family planning policy work. The first innovation I would like to share is one PROPEL Health is working on in Liberia. PROPEL Health partner Samasha, along with PRB, Palladium, and a local consultant, are providing technical assistance to the Ministry of Health and other stakeholders to support the adaptation of WHO's self-care guideline. This is based on Uganda's recent experience innovating on the policy development process. In March 2022, Uganda set out on a 5-phase process to develop national self-care guidelines. They took the standard approach of establishing a working group, conducting a situational analysis, and developing draft guidelines. Normally, guideline development goes through various steps of getting stakeholder input and validation, and then they're approved and signed by the minister or other relevant decision maker. However, the idea of sandboxing a new policy or regulation is an innovation PROPEL Health is exploring. Sandboxing is an extra step in the policy development process that tests implementation of the policy in a defined place for a defined amount of time, with the goal of ensuring that it is beneficial or effective prior to its finalization and broader application. This allows stakeholders and decision makers to see what works and what doesn't and edit the policy prior to national rollout. In the case of self-care in Uganda, stakeholders agreed on a set of self-care interventions for the guideline and selected Mukono district to test it over several months. The sandboxing approach led to some small revisions in the self-care package. For instance, the original HIV self-test kit was replaced with a different brand due to labeling issues. The malaria test was found to be impractical for self-testing, and the color changes in the urine dipstick were hard to read, so it was removed from the package of self-care interventions. Another great thing about sandboxing is that it revealed some implementation issues, such as how facilities record self-care clients, the importance of SBCC in self-care rollout, and easy ways to leverage existing provider-client interactions to promote self-care. So sandboxing a new policy allows the Ministry of Health to plan for those implementation issues prior to a larger rollout. And as such, government can be proactive in troubleshooting rather than having to fix something reactively when a policy has gone to scale. PROPEL Health's support to Liberia in replicating this process is ongoing. We've just finished the landscape analysis and have started drafting guidelines. We hope the sandboxing will begin in early 2025, with the results feeding into finalizing the national self-care guidelines around this time next year. So the second innovation I want to share was implemented in Guatemala with PROPEL Health partner, the Busara Center for Behavioral Economics. The project took a never-before-used approach to accelerate implementation of gender-based violence, or GBV, policies, improve access to and use of quality GBV services, and improve the well-being of GBV survivors. While Guatemala has a strong policy and legal framework for preventing and responding to GBV, violence against women is still the most reported crime in the country, and it is likely underreported. To unlock new approaches and tools to accelerate GBV policy implementation, PROPEL Health and Busara use behavioral systems mapping to identify and apply behavioral insights. The first step was identifying the actor behavioral model. This involved conducting qualitative and quantitative research to map the whole GBV system in the country. It connects all the players, policies, protocols, and elements that can affect the journey of a GBV survivor through the system, and the elements that can affect the outcomes that survivor may experience based on the policies and decision makers in place. From this map, an actor behavioral model was created, which represents the journey a GBV survivor might take through the GBV system and how various actors might affect that journey and its outcomes. From the actor behavioral model, Busara was able to design a computational lab, which is a digital infrastructure that is able to run thousands of simulations in the model of the GBV system. In step 3, we use the computational lab to control variables in the GBV system, while only tweaking one at a time to identify where outcomes for the survivor are improved. For example, what happens if we increase the number of hospitals, or if services are offered in a wider variety of Indigenous languages? In other words, in this step, we're adjusting variables to see what had positive outcomes on the well-being of the survivor within the GBV system and which ones had negative outcomes or had no change. In this graphic, you can see that one tweak to one policy increased the aggregate well-being from the baseline. So these controlled analyses help us identify interventions that are likely to improve the GBV system and the outcomes for survivors, and others that might not improve the GBV system at all or even make outcomes worse for survivors. In the picture here, you'll see a couple of interventions written in black, pointing to various leverage points in the system. For example, having community health workers provide education about GBV to communities can help friends and families be a stronger support network for survivors. This methodology is really exciting because it has the potential to test policies and interventions efficiently prior to investing the time and money in a robust intervention or even a small pilot. It can be applied to all sorts of technical areas, not just GBV or FP. So the final innovation I'd like to mention is integrating climate change data into a landscape analysis of community health workers, or CHWs, in Côte d'Ivoire. Climate change is affecting Côte d'Ivoire in multiple ways. It is experiencing more weather events and increased frequency of forest fires and floods. This is projected to increase extreme poverty by 1 million people by 2030, disrupt health services, increase waterborne disease, increase food security, and so on. Here in the chart, there are 10 top causes of death in Côte d'Ivoire. And while the country has seen improvements in health indicators, many will be exacerbated by environmental factors. For instance, increased temperature and rainfall can significantly increase malaria transmission. In May, PROPEL Health published a situational analysis of CHWs in Côte d'Ivoire. As part of this analysis, PROPEL Health looked at the risk of effects of climate change on the work of CHWs. Since CHWs are at the forefront of responding to outbreaks, retaining links to health services, and preventing and treating malaria, diarrhea, nutrition, and other health issues, and these are poised to increase by climate change in Côte d'Ivoire will significantly affect their work. As part of this CHW analysis, PROPEL Health interviewed district health representatives, technical and financial partners, and CHWs themselves to explore intersections between climate change and CHW planning, deployment, and financing. This revealed that, in general, climate issues have not been integrated into the CHW program in Côte d'Ivoire. For instance, CHWs do not receive training on disaster preparedness, and there's no specific funding available to integrate climate-related disease control efforts into CHW activities. Overall, the analysis shows that the risks of climate change are significant in Côte d'Ivoire and that CHWs can play a crucial role in combating these adverse events, even if it is clear that they are not yet being used for this purpose. There were several recommendations that emerged, such as integrate climate data into CHW distribution decision-making, organize discussions to strengthen stakeholder understanding of the integration of these issues, and explore financing opportunities to integrate climate mitigation into health. Thank you for listening. I'm now going to pass this back over to Jake Gribble to moderate the Q&A portion of our webinar.
Thanks, Erin. And thanks also to Laura and Francis for really insightful presentations. So we've been talking about either getting policies developed, as in the case of Nigeria or Liberia, or implemented more effectively, Madagascar and Guatemala. Yet many people take the policy component of family planning for granted and focus really only on service delivery issues. Yet what we are seeing through these policy examples is how policies lay a foundation for services to be delivered, along with better accessibility, quality, and affordability. So to the three speakers, can you comment briefly on how you see the relationship between better policies and better health outcomes, please? Erin, do you want to kick off the responses?
Sure, thanks, Jay. So I think the policy development process presents an opportunity to ensure that service delivery is state of the art, that it's incorporating new evidence-based approaches or treatments, and that it allows a country to standardize the quality of care they want to see in the country. There will always be challenges to quality of care, like an uneven infrastructure or stockout challenges that may be localized or across the board. But having in place state-of-the-art policies at least guides health managers and providers all throughout a country on the expectations for care. This is particularly essential in a decentralized context, in my opinion.
Thanks, Erin. Laura, and then Francis. And Francis, when you think of your response, I'd like to ask about going from kind of a national policy, which is what we've been talking about with the guidelines, and how that impacts state level or subnational implementation in a context where health has devolved. Laura.
Yeah, so I agree with Erin, and I'd say in addition to quality, I think it's important to consider equity as well. Madagascar's most recent CIP made a concerted effort to include women with disabilities. So policies that promote equity in access to reproductive health and family planning services to women with disabilities should promote better health outcomes, even for the most marginalized.
Thanks, Laura. Francis.
Thanks a lot, Jay. That is a very important question. And when I think about it, I think of it from the aspect of how do we develop our policy, right? Because we have to start from the scratch. So the policy development process is very critical. As we could see in the Nigerian example, we started from making sure that we had extensive evidence that was contextual, that was based in reality. Because oftentimes what we have is that we have policies that are not based in reality. So we have national policies and then they go to subnational level and they meet subnational unrealities. So the most important aspect of it is making sure that we develop policy the proper way. So when we're talking about that, we have to make sure that we have evidence that speaks to the real needs at the subnational level. So for instance, making sure that it's contextualized, it's applicable to different settings. And you raised a very important point. For instance, in the Nigerian context, we have a federal system. So policies are developed at the national level, but each state will have to adapt it based on their own context, right? So in this kind of situation, the policy document has done is that it provides a guide that different states can then adapt to their own context. So first of all, you need to have very strong evidence of what is applicable at the subnational level. And then you also need to give that flexibility for states to be able to adapt it to what actually fits their context. Now, another important success factor, I would say, is stakeholder consensus. If we have a policy that is based on stakeholder consensus, then it makes the implementation a bit easier, because at the time of implementation, most people already agree that this is what should be happening, this is what needs to be happening. And with this, I'm talking about inclusion and inclusivity. I could go on and on. So basically making sure that our policy is grounded on reality, is grounded on evidence. There is stakeholder consensus and inclusion, and all the people that need to be at the table where those policies are developed. And then finally, the enabling environment for that policy to be implemented, the how. And that is where, for us, the biggest portion of the job that our policy implementation work requires.
Thanks, Francis. Very thorough, and really the importance of linking the national to the subnational and that subnational context where policies actually get implemented. A second question that I have for the presenters is to think about a key element in policy implementation is the use of data to drive performance. Laura, can you talk a little bit about how data is critical to ensuring that Madagascar and other countries can achieve their family planning goals through using the get associated with it? And Erin, can you share any thoughts about how incorporating climate data and insights into climate change might be useful to support community health programs and their efforts to increase access to family planning?
Okay, so our CIP performance monitoring work is using a data use for improvement approach. So this approach uses indicators to monitor both the implementation of the CIP through process indicators and the results of the work and investments, so for outcome indicators. Both sets of indicators are important, both to flag issues or obstacles and to reassure country leaders that the country is on the right track. So, for example, I mentioned that a gap analysis in Madagascar showed a lack of resources for demand creation. But I didn't mention that the demand creation performance monitoring indicators were also well below target. So having these 2 points of data that were aligned forced the Family Planning Technical Working Group into action, and they were able to mobilize money from Médecins du Monde for these activities. Likewise, the President of Madagascar's engagement led to the very ambitious goal of 60% modern contraceptive prevalence rate by 2030 in the country's FP 2030 commitment. So while the goal seems a bit too ambitious, it is certainly motivating this more than 1% annual increase.
Thanks, Laura. Can you talk a little bit about the community health worker, climate, and how it might contribute to better use and uptake of family planning?
So So I think that this innovation of integrating climate data into community health workforce planning and deployment is very thought-provoking for me. There are increasing efforts to invest in community health workers as essential to primary health care, and they have been shown to be extremely effective in meeting women's demand for family planning. And they also provide an essential link between communities and the greater health system. So data is playing a key role in that in general right now. Several countries are using geospatial analysis to optimize the deployment of CHWs to ensure geographic coverage, equitable access to health services, and the like. So I could see how the integration of climate change projections, such as perhaps where flooding might be more likely in the near to medium term and thus increased risk of malaria, for instance, could help countries with their human resources for health planning, looking perhaps 5 or 10 years in future, and include such data in their projections and their training plans and such on how many CHWs they might need and where they would need to be deployed. They can also be integrated into CHWs themselves, can also be integrated into disaster epidemic outbreak planning as trusted members of communities and thus be effective extensions of a government response. But I think we need to ensure that we're not overburdening CHWs, expecting them to do too much and just adding too much to their essential workload in their package that they're providing. So adding climate risk mitigation and response efforts to this scope of work should be tested to ensure that it has positive outcomes both for the communities that they serve and the CHW themselves.
Thanks, Erin. So let me go to the question that's in the question and answer box about what's the difference between sandboxing and implementing a pilot program. And I think this gets to the Liberia work, but it also may kind of trickle into Francis as we think about the national and subnational. But Erin, can you talk a little bit about sandboxing and how it's different from implementing a pilot program?
Sure. Well, there's certainly sister concepts, right? You're testing something to see if it works under real life conditions. I think the biggest difference for me is understanding that we're not testing the intervention. Usually policies are sort of, setting forth things that we know that have evidence base. For instance, with self-care, we're not testing whether women can self-inject. But when you sandbox a policy around self-care, you're testing how does that package that you've created and the policies, the SOPs of how it should be implemented, how is that received within a community, understood by the health managers, the facility? How does it work with all of the health systems issues like procurement and such? It's testing more of like, how does that policy roll out? And is there something unclear about the policy? Is there something unrealistic about the policy? That sort of thing. It's not a proof of concept of the actual things it's trying to achieve from the health intervention perspective. I think self-care is a little bit of, how should I say this? Like, so innovative and new to many contexts that there's a little bit of hand in hand of even sensitizing people about self-care in and of itself and sort of ensuring that people are a little bit on board with that. I see in the Q&A that somebody else also asked if there was any challenges around the sandboxing concept. I would certainly defer to my Samasha colleagues on, what they might have experienced in Uganda. But in Liberia so far, because of where we're at in the process, it's not so much that there's any concern with this sandbox, like adding sandboxing or piloting of the policy to the process. We haven't really received too much concern comments about that. I think where it is just going to some stakeholders and just even talking about self-care and what that looks like. There's been a few questions as to whether that's a good thing. And I think that the sandboxing and the policy development process around self-care will be a positive one in the sense that also brings people on board. I think Laura also is talking about bringing people on board, and Francis as well, of agreeing and sort of sensitizing people people to what the policy is hoping to achieve and just building momentum and support for it.
Great. Thanks, Erin. I think it's really a useful concept because it helps us understand, are we getting it right with the policy on a smaller scale rather than getting a big national policy approved, and then you start finding all the challenges and difficulty with implementing it. By focusing on a smaller geography or a district to see how well is this going to work and is it understood, and the commitment to implementing it, making adjustments before approving it at a national level, I think is a useful endeavor. And I'm really happy to see that we're trying it, especially on something like self-care that is a broad set of kind of interventions and products and services.
If I could add one more thing, I forgot to mention that I think it also, well, one, it speaks to just general project management where they say planning should be, front loaded, right? And then it leads to better execution. But also I think it invites more voices and experiences into the policy development process, that it's not just a bunch of experts in the capital kind of figuring out what should be in a policy, but when you bring it down to the actual, front lines of the health facility and the communities that they're serving, there's more opportunity to get diverse voices within that process to then feed up to the national level and the National Ministry of Health on, how is this working for them?
Thanks, Erin. Francis, I see a question from Jeff about, is it difficult to convince state insurers to cover family planning services when donors are providing the family planning products and services free or highly subsidized? So any thoughts or any insights about what's been the experience in working with the state insurance agencies on this topic?
Thanks, Jay. That's an excellent question. And each time we engage with subnational actors to move this forward, there are always two major questions. One, isn't donors already covering this? And the second one, it's going to be too expensive and will break our scheme. And the response to these two questions is based on what we're just talking about right now, data and evidence, right? So we are able to effectively use evidence to provide information to people because fact speaks when people can see the facts. So for instance, with regards to the first question, aren't donors already covering it? Being able to demonstrate that donors are doing a lot, but despite that, there is still a huge funding gap. We're not meeting our targets yet. We have to increase our targets. And even then, there's still a lot that is unfunded. And donor funding is not sustainable. So putting together very compelling evidence to be able to make that conviction usually works. Now, the second part of it is it's going to be expensive to break our bank. How do we counter that evidence as well? So part of our recommendations in the guideline document is recommending that state health insurance schemes conduct, financial feasibility. I spoke about technical feasibility, what is technically applicable, what can be provided at what level and all that. Operational feasibility, regulatory, but perhaps financial feasibility is the one that they care most about. So many states go ahead to do what we call an actuarial analysis that estimates the additional risk of including family planning into their benefit packages. And for many of the states that have done it, like Lagos State, it actually showed that it's financially feasible. So using that kind of evidence to show that you can include a comprehensive package of family planning services into your scheme without breaking the bank is also another very compelling argument. And also evidence, the third part very quickly, is that evidence is also used to demonstrate to them that not just does it not break your bank, but it has additional benefits for you. So for instance, by spending on family planning, then you don't have to spend on additional maternal and child healthcare services. It also has economic benefits as well, like we all know. So perhaps I should stop here.
Thank you, Francis. Good answer. And it's not as simple as we might think. There are different types of evidence and different aspects of the case to make. So let me thank Shyami and Suneeta for opening our webinar. I want to thank also Francis, Laura, and Erin for sharing insights on how the policy process can support improved quality and accessibility of family planning services and programming. When we return to Pathways to Progress, we can see a project like PROPEL Health advances knowledge, and supporting agency through the example of the self-care work. Much of our work supports stronger health systems. The examples related to community health workers, enhancing health insurance benefits packages to include family planning, strengthening capacity to execute CIPs, and if dreams come true, not just CIPs, but other types of strategies and policies. And efforts to support better implementation of gender-based policies align with improving supportive social norms and policies, that third pathway. But the reality is it's less about how we contribute to each of these pathways and more about the key ways that women's family planning and reproductive health needs can be better supported by addressing the individual's needs, strengthening the systems through which services are provided, and improving equity and the context where women live and seek care. The opportunity for each of us to remember is that while different pathways to progress for sexual and reproductive health have different landmarks and milestones, those pathways also need to cross, overlap, and head toward a common destination, which is our shared goal of improving sexual and reproductive health. Thank you so much for your time.